Good evening, and welcome to our first educational gathering of 2021. My name is Karen Van Til, and I'm on the leadership team of Healthy Women, Healthy World. If you are new to our group, we are thrilled that you have joined us. And if you're a Healthy Women, Healthy World veteran, it's great to see you again. Healthy Women, Healthy World is a volunteer-led community united to mobilize as champions for women and their families impacted by global health issues. We are supporters of Medical Teams International, and we gather quarterly for free educational events. The idea is to come together to learn about and discuss real-world, interesting global health topics. Our topic this evening is a way forward in a COVID-19 world. We are thrilled to be joined tonight by Dr. Ruann Barnabas and Dr. Janet England, who are here to discuss COVID-19's impact around the world, the vaccines, and their effect on pregnant women and children. We also have the honor of hearing from Medical Team's President and CEO, Martha Holly Newsom. Before we hear from another member of our Healthy Women, Healthy World team to lead us in a reflection, Jaya is here to share a few Zoom tips. Jaya?
Hello, everyone. I'm Jaya Lehman. I am medical team staff providing support this evening. Please use the Q&A feature at the bottom of the control panel for any questions that you would like to ask our presenters. You may add these at any time during the program, and we will answer them at the end. In the upper right-hand corner of your screen, you may toggle between views to make the speaker or PowerPoint image larger, depending on whether we're doing a screen share. We are recording the webinar to be able to share it with those who weren't able to join us. Finally, we welcome your input as we continue to improve our virtual events for 2021. Please take a moment to complete the survey available at the end of our program. I would now like to introduce Tammy Messina, Director of Advancement for Medical Teams, for a brief reflection. Tammy.
Thank you, Jaya, and good evening, everyone. To start our time together, I would love to share a verse from the Old Testament in the Bible with you, Micah 6:8. He has showed you what is good, and what does the Lord require of you, but to do justice and to love kindness and to walk humbly with your God. So this evening, we gather because we care about justice and what is happening in our world with COVID-19. We love kindness, and we want to come together in a humble way to learn how we can make an impact and make a difference. Thank you for joining us. So now I'd like to turn it over to Medical Teams International President and CEO, Martha Holly Newsom. Martha.
Thanks, Tammy. And I want to welcome everyone. So good evening to all of you. And for those of you who don't know me, I'm Martha Newsom, President and CEO of Medical Teams International. I'm so glad that you could join us today. I want to especially thank our two guests, Dr. England and Dr. Barnabas. We're super excited to hear your insights on the global impact of COVID-19 and the vaccine's effect on women and children, especially pregnant women. We're looking forward to hearing from both of you. So a lot has changed in our world since our last Healthy Women, Healthy World gathering. We've seen the rollout of 2 vaccines, and at least there's a bit of emergence of new treatments to combat the virus. So at long last, I feel like we can see this little dim light at the long end of this COVID tunnel that we've been in. And as the vaccinations start across the US, there's some hope that we'll start to see a slow return to some of the normalities that we enjoyed before the pandemic. I know that many of us are still continuing to cope with the constraints that are caused by the virus. Some of you are working from home, you've become teachers, supervising your kids' schools, and there's been changes to people's jobs and industries. Some of you may have contracted the virus yourself or dealt with a loved one who had it and are dealing with the impact of that. So in short, truly all of us have been impacted in some way. And this has been an unprecedented time for our organization. Since the virus began to spread last March, our team at Medical Teams boldly stepped up to respond to COVID-19. Many of you know that we pivoted the entire focus of the organization to respond and begin caring for communities. We provided emergency mobile dental services and turned some of our vans into COVID testing sites that are continuing to test today. Since last March, we've conducted more than 450 COVID testing clinics right here in the Pacific Northwest, including over 29,000 patient encounters. I love that word encounter, because we sincerely hope that each person that we've served encountered loving care when they came to us. Our volunteers and staff have worked tirelessly in these mobile clinics, providing free testing in hotspots where the cases were high. At the request of Washington and Oregon, we've covered under-resourced regions to ensure that vulnerable residents were given equal access to testing, places like Yakima County and Washington. We've trained nearly 90 volunteers who are serving alongside our staff and have collectively reached tens of thousands of lives. Internationally, we're serving in places where the healthcare system is weak due to disaster and conflict, places like Guatemala and Bangladesh. As COVID-19 continues to spread and as additional variants are found, it's more evident than ever that there's far too many vulnerable people and too few resources for their communities to cope with this crisis. A virus like COVID-19 only adds to the life-threatening illnesses and crises that women and children face every day. Pregnant women are afraid to seek care because they're worried about catching the virus. This pandemic adds fear upon fear to every other hardship that people are experiencing. In the areas where we work, such as refugee camps, the spread of COVID can be devastating. Many refugees have underlying health conditions like malnutrition and malaria and respiratory infections, which makes them more susceptible to this disease. We are working with ministries of health and other partners to train and equip local medical staff to deal with COVID, and are training community leaders with life-saving health messages as well. In some places, we're providing COVID treatment, like in Bangladesh, where we converted one of our primary healthcare clinics into a COVID treatment center. The next big challenge to overcoming this pandemic is equitable vaccine coverage. We are exploring how we can best provide vaccines or support vaccination programs, because we believe that no one is safe until we are all safe. And we want to make sure that those who are the most vulnerable, especially women, children, migrants, and refugees, that they hear this message. You are not alone, and you're not forgotten in this COVID battle. In the face of uncertainty, we find strength in our calling. Daring to love like Jesus, we boldly break barriers to health and restore wholeness in a hurting world. This pandemic has offered us many new ways to live out this calling. Thank you for partnering with us as we navigate and respond to this ever-changing, ever-demanding pandemic landscape. And thanks again for joining us this evening. I hope that your time that you spend with us will leave you encouraged, informed, and renewed. And now I have the pleasure of inviting our first speaker, Dr. Barnabas, to take over this virtual platform. Thank you, Dr. Barnabas. I think you might be muted.
There we go. That is going to be the catchphrase for the Zoom pandemic. Good evening, everyone. I'm really delighted to be with you this evening. My name is Mrna Barnabas, and I'm an associate professor in the departments of global health and allergy and infectious diseases at the University of Washington. It's great to be with you this evening. I wish we could be together in person. I'm going to talk today a little bit about public health research during a pandemic and give you some updates on the COVID-19 pandemic, where we are and where we are with vaccines. I also wanted to talk a little bit about how we conduct public health research during a pandemic. It's quite interesting, and it has made us be innovative in ways we hadn't thought about previously. And so there are some silver linings working through this pandemic, and as Martha said, we can start to see some glimmer of hope as we move forward in the next few months. Please do let me know if you have questions, especially points of clarification during the presentation. Don't hesitate to chat, and Jaya or her colleagues will let me know if there are questions for clarification. And then, of course, during the Q&A session, I'm very happy to take questions as well. So today I'm going to discuss where we are in the global pandemic. I'm going to talk about strategies that we use to prevent COVID-19 and really think about how we can stop transmission, and then discuss where we are going with research and what the priorities are moving forward. I told Jaya that I did not want to prepare my slides too far in advance, because this is such a moving topic, and every day we learn new information. So these are two websites that I use often on a daily basis: the Johns Hopkins Coronavirus Resource Center, which has been tracking global cases and deaths since the very beginning of the pandemic. And it shows that today we are at over 111 million confirmed cases of COVID-19 globally. One important caveat to that is that it is almost certainly an underestimate of the number of cases of COVID-19. We have diagnoses, we have estimated cases, but we're still probably undercounting the number of cases. Worldwide, there have been almost 2.5 million deaths. In the US, there have been over 28 million cases and just about 500,000 deaths, as we saw commemorated this past weekend. I remember the day actually very clearly when we were at 5 million cases in the US, and it seemed like an unfathomable number. And here we are at almost 30 million cases. The map on the right shows the distribution of cases globally. In the darker color, there is more than 1 in 20 cases, or more than 1 in 20 people have had coronavirus. And then in the lighter colors, there are fewer cases. And you can see here, leading is the US, UK, Europe, and then South Africa, and then South America, and Russia, where we actually don't have very good statistics. But you can see that in many places where we look, we do see many cases of COVID-19. The death rates have been different in different parts of the world, and I'll show you that in a minute. What has been good news over the last few weeks is that the average numbers of new cases globally, the average number is declining. So you can see here the US leading the number of cases, and then in the last month, or just a little less than a month, the actual number of cases coming down quite steeply for the US, average number of new cases per day. So you can see here we were at, well above 650,000 cases a day, and now we are below 400,000. Sorry, now we're this is the total number of cases globally. You can see we were quite high globally, and that's come down in in many places, including quite impressively in the US and UK, a little less so in Europe, South Africa and Brazil. These are the leading countries. And you can see the rest of the world is just this small part of the figure here in gray. So we have this good news. We have average numbers of cases globally declining. There are many reasons for this. It's in part due to the precautions that everyone is taking to reduce transmission. So our behavior, it's in part possibly due to the vaccine in some settings. That might be the UK, where vaccine coverage is quite high. It might be due to seasonal variations in the number of new cases as well. That's where we are globally. But I do just want to remind you that this was reported today by the CDC, that the risks are still high until we have high coverage of vaccination. This report is from a COVID-19 outbreak among attendees of an exercise facility in Chicago, Illinois. And these were participants who took part in a class that was a high intensity fitness class. And you can see here of the 81 attendees at this high intensity fitness class during 1 week, because there was one infection, 68% developed COVID-19. So we still have we still have high risks of transmission, even though overall the number of cases are falling. And so the recommendation here from the CDC is, the recommendation from the CDC here is that gyms should require masks during exercise, require physical distancing, decrease class sizes, and improve ventilation. And this is true for all indoor settings. So even though we see quite reassuringly the number of cases overall and here in the US come down, we still have these outbreaks. And so we're continuing to practice all the strategies we know reduce transmission. So what can we do to prevent COVID-19, and how can we stop transmission? And here I want to switch to talking about transmission within households. We know that within households, the risk of COVID-19 can be quite high. In the literature, the reports are between 10 and 40% of people within households will acquire COVID-19 if one household member has infection. So you can see here in these households, in the yellow figures are people who have COVID-19, and in the green figures represent people who do not yet have COVID-19. And there are contacts here in this solid red line where COVID-19 or SARS-CoV-2, the virus that causes COVID-19, is successfully transmitted. Or here there's contact between, in this dotted line, and a person who has COVID-19 and one who doesn't. And even though there's contact, there is no transmission in this particular case. And of course, contact happens between households and within households. So what are some of the factors, that could determine whether or not transmission occurs within households? So we think both about the viral factors and about the host factors. So for example, if there is a lot of virus, the viral load is high, is more contagious, infectious, as we have seen with some variants, then we expect transmission to occur easily. In the same way, behavior can determine transmission. So if we have individuals within households who are isolating out of the home or who are using separate spaces through the home, we can expect that transmission will be less. We also can use different types of medications and different types of agents like vaccines to prevent transmission. So we know that we can use medications like treatment to bring down viral load, post-exposure prophylaxis, that's where you take treatment to prevent infection, after you've been exposed to prevent acquiring the infection, and vaccines, of course, the gold standard to prevent transmission. So you get the vaccine and that protects you against exposures. And I don't want to talk a lot about mathematics, but I just wanted to share that when you think about transmission, we think about how long someone is infectious for, what the rate of contact is, and how transmissible the virus is. And so we really try and focus all our interventions on reducing transmission by decreasing the amount of time people are infectious for, decreasing the physical contact between individuals, and then using vaccines, PEP and PrEP to decrease transmission between people. And you can express that all mathematically, and that leads to, that's how we calculate R naught, or the basic or effective reproductive number as it's known. And it, as a infectious disease modeler and infectious disease physician, it's wonderful to turn on the radio and have people actually talk about the effective reproductive number. And we know it's hovering above 1. That means every infected person infects at least one person. And through all the interventions that we have planned, our aim is that we drive down the number of newly infected people to less than one newly infected person, and that will help us eliminate this epidemic. So I did want to share that really interesting bit of science with you. We can drive down the number of people who are infected by vaccinating individuals. And if we vaccinate, if R naught is 2 and we vaccinate 50% of people, we can drive the effective reproductive number down to 1. So that is how we think about vaccination and transmission. I'm going to just briefly share with you some interventions that can prevent, that were tested to prevent SARS-CoV-2. And one of them is well-known, hydroxychloroquine. We heard a lot about it early in the pandemic. It's a repurposed medication, and there was a lot of hope that this medication could prevent SARS-CoV-2. And we were hopeful because for decades we have had studies that show that hydroxychloroquine has antiviral properties. It had been studied for the first SARS outbreak and MERS as well, but the studies were not completed. So we didn't know whether or not hydroxychloroquine could prevent SARS-CoV-2, and this was a good candidate because hydroxychloroquine is safe. More than 6 billion doses have been given all over the world, and it is widely available. So this is a kind of repurposed medication. If we could show it was effective, we could really make it available all over the world. And for this reason, we set out at the University of Washington to study hydroxychloroquine to try and really understand, can it prevent SARS-CoV-2 infection? And we wanted to do the science behind this to have the evidence to know whether or not it's a worthwhile undertaking for us. And so we conducted a randomized control trial from the University of Washington to test this medication. And we were able to enroll 829 participants from 41 states over just a short amount of time in order to test this medication. And we had very good retention of participants, over 90%. And the participants who took part in the study provided specimens every day for 14 days within households. We recruited close contacts of people who had SARS-CoV-2. So just to go back to this slide here, you can see here the infectious individual here in yellow. We recruited all their contacts, everyone who lives in the household, in green, and we sampled people who lived in the household in green every day to try and see how many cases of SARS-CoV-2 there were. We gave half of the participants hydroxychloroquine and half received a placebo equivalent. And then by comparing these two randomly assigned groups, we could test hydroxychloroquine and see whether or not it worked. And so how could we conduct so this just describes the design that we enrolled the close contacts and we randomized them. So they randomly went to either the hydroxychloroquine or the control group. And participants didn't know what type of medication they were taking. They just knew they had to take it every day for 14 days and collect their specimens. So how did we conduct this trial with all the medical space dedicated to taking care of participants? And also we didn't want people who were potentially infectious to come in. So we did the study entirely remotely. Participants were recruited via social media. So on Facebook and other social media platforms. They signed up on the web using the same kind of form that you would use if you were signing up for a quote for insurance, for example. We couriered them a box with a guide and all the swabs for 14 days. They collected their own specimens, mid-nasal specimens, and a courier picked up the specimens and brought them back to the lab for testing. And this design was based on Dr. Helen Chu's Seattle flu study, which was the mechanism through which we first identified SARS-CoV-2 here in Washington State. So she was part of our team, and we were very fortunate to build on her expertise and to be able to test this medication using these entirely remote methods. So participants did not have to come in to the hospital at all. And it also allowed us to reach people all over the country, 41 states. And this is what we found at the end of the day. For the 829 adults who we recruited, there were 53 infections in the hydroxychloroquine arm and 45 infections in the placebo equivalent arm. And so this led us to understand quite clearly that hydroxychloroquine did not change the incidence of SARS-CoV-2. So it did not protect people against getting SARS-CoV-2. And we've learned since then through multiple well-conducted studies that hydroxychloroquine does not treat SARS-CoV-2 or COVID-19 either. And it was really important for us to have the right answer here in as quick a time frame as possible, because if we did not want to waste any time or energy providing treatments that were not useful. So we recruited the study very quickly. We had the idea in March and started in March, and then enrolled participants until August, and then we were able to have the final answer in August. And so our motto during that time was to be responsive, to be of service, and to do excellent science. Using exactly the same design, we went on to look at monoclonal antibodies to prevent SARS-CoV-2. And we did that in households as well, another randomized study. And we just looked at the results from the first 400 participants. And overall, we found that there was a decrease in transmission of 50%, and there were no symptomatic individuals for people who received the monoclonal antibodies. So overall, monoclonal antibodies seem very promising. We have just the initial results. We're waiting for the final results, which we should get in the next couple of months. But overall, monoclonal antibodies seem to be effective to prevent transmission of SARS-CoV-2, and also they are very safe. So using the design that we built, we were able then to build on this infrastructure and the science here and test a different agent, monoclonal antibodies. And these look promising, but we'll wait for the results in just a few months. So in the last few slides, I want to talk about what the priorities are for research moving forward. And I wanted to also share this figure with you. These are the two vaccines, the Pfizer and Mrna vaccines that are available under the EUA in the US. And you can see here that in this study, it was also a randomized study. People who got the vaccine really didn't develop COVID-19. So here you can see that the numbers of cases in the vaccine arm are very low over time. But if you got the placebo, many people did go on to get COVID-19. And so this is the kind of result that gives us good confidence in the vaccine. It's highly effective and it was very safe in both these studies. And today we heard the Johnson & Johnson vaccine is under review at the FDA, and we hope that we will have news about EUA for that vaccine as well. Who is getting vaccines all over the world? So this figure shows very nicely who is getting vaccines and where. You can see here in the US, we have in the darker colors about some of the highest vaccine coverage. I can share the story of South Africa, where they started vaccinating actually just a week ago. Last Wednesday, they started vaccinating their healthcare workers using the Johnson & Johnson vaccine. And they are vaccinating one person every 5 seconds, 40,000 people a day. And just over this week, this color has gone from entirely gray to light blue. And we hope that we will see this throughout the continent and all over the world, that we're able to vaccinate, especially in areas where we have high numbers of cases for COVID-19. Who is working for equitable access to COVID-19 vaccines? The organization is called COVAX. It is a multilateral organization, including the WHO and Gavi, and they are really working hard to build vaccine country readiness and work on delivery. And they are focused on the delivering vaccines because we need a scheme to share vaccines, as Martha said so well. No one is safe unless we're all safe. The coronavirus pandemic has destroyed livelihoods and claimed the lives of more than 2 million people worldwide. These vaccines, as I just showed on that map, are not equally distributed, and COVAX hopes to deliver more than 2 billion doses to people in 190 countries in less than a year. And in particular, COVAX wants to ensure 92 poorer countries will receive access to the vaccines at the same time as the 98 wealthier ones. And the scheme is led, as I said, by Gavi, the Global Vaccine Alliance, Gavi, and the Coalition for Epidemic Preparedness Innovations, CEPI. There are more than 230 vaccines that are in development. I think more than 60 are in clinical trials. So we hope that we will continue to have good vaccines. And I just wanted to end on this note. It's been quite notable that during the COVID-19 pandemic, as an infectious disease physician and scientist, we have seen so much of science in the media as it's happening. And so we have seen also a lot of public debate about science. And Holden Thorpe, who is the editor-in-chief for Science, wrote this very nice editorial. And I this was one of my last slides. He said, if we want the public to understand that science is an honorably self-correcting process, let's do away once and for all with the idea that science is a fixed set of facts in a textbook. Instead, let everyone see the noisy, messy deliberations that advance science and lead to decisions that benefit us all. And so I'm so glad that you have this particular this particular talk, and that you do this all the time, and you grapple with the science, and you do good work delivering interventions. Thank you so much for all your work. Thank you so much for your attention this evening. Thank you to the collaborators on all my work. Stay safe. I love this poster from Budapest, which says, stay home, no kisses, no handshakes. And then it says, cancel your meetings and dates. Those who care about you will wait. So I'm very grateful for your attention, and I'm happy to take questions. I think we're going to have a Q&A after Professor Janet England speaks. Janet England is a professor of pediatric infectious diseases at the University of Washington. She's my colleague, and it's really my immense pleasure to introduce her today. She's based at the University of Washington and Seattle Children's Hospital. She studies new viruses, viral vaccines, and novel agents for the treatment and prevention of respiratory viruses, including influenza, respiratory syncytial virus, RSV, and SARS-CoV-2, COVID-19. Janet, welcome.
And thank you so much, Ruanne. It is, I'm just trying to get my slides here. It is a pleasure to follow you. You've done the hard work and introduced what's going on. So I think that's great and helpful and might make my job a little easier. Ruanne's, some of her work in novel treatment and prophylactic approaches has been really important. I just, the audience should realize that this kind of work is not simple. It takes not only innovation and creativity, but it takes a lot of hard work. And she and her colleagues have done an amazing job. And I'm not going to be able to show quite so much work in pediatrics because I will tell you why. We are a little bit behind the game in our issues with pediatrics. And let me tell you why. I'm going to be talking about COVID-19 in children and briefly go into pregnant women and discuss what we know and what we hope to find out. I do have financial disclosures. I receive research support because I do vaccine studies from the companies that make vaccines, including Glaxo, Novavax, AstraZeneca, Pfizer, and Merck, and I serve as a consultant for some of these companies. This is a coronavirus picture made by my son about 20 years ago. He's now 25. I want to say that I've been studying coronaviruses for a long time. My son knew about coronaviruses probably before he knew about flu or or the history of the United States, probably because I talked about it so much. I will be talking about coronaviruses, the epidemiology, some clinical information, and what's new about vaccines for children and pregnant women. And just this little picture, I want you to see that these are these little spike proteins that everybody's talking about. The spike protein is what your body interacts against to make antibody, and it's the antibody or the molecules in the body that fight against this spike protein that prevent one from getting sick with COVID-19, as well as the other coronaviruses that came before COVID-19. You've already seen this nice picture from the Johns Hopkins website. Everybody uses this. This is a reflection not only of how much disease there is, but who can get tested. And certainly the United States stands out here, both for a number of cases and who can get tested. This is not good. I just want to make sure that everyone understands it's not good that we're leading the world in the number of cases. It's actually quite pathetic, in my opinion, that in a country with the resources and the science and the smart people that we have, that we here look as red as we are. I'm going to spend the first few minutes talking a little bit about the Seattle flu study, which was what Ruanne already talked about. The Seattle flu study started in 2018. Helen Chu is the chief investigator for the adult studies, and you've had Helen Chu speak to you. She's a wonderful, great speaker, a good colleague of mine. She headed up the adult studies. I headed up the pediatric and family studies. So we've been working together now for over 10 years. And all these other people have contributed immensely. And I just thought I'd give you a little bit of background. I think she has shared some of this background in a previous talk, but to put things into perspective, I just want to say it was 1 year ago, February 28th, 2020, when Helen and I went to draw blood from one of the very first patients in the United States who got infected with SARS-CoV-2. So it's a long time ago, it's a year, and so much has happened. What we were able to find with the Seattle flu study, using the same type of home swabbing and mailing in swabs that Ruanne described in the studies she did, was the first case of community transmission in the United States in an adolescent patient attending a Seattle Children's Hospital clinic. This patient now is affectionately known as WA2. WA1 was a a gentleman who traveled from China. Hua Tu is someone who had no exposure to anyone, and he came up with SARS-CoV-2. He had a sample collected February 21st. We identified it February 28th. And since that time, everybody's life, including ours, has been in an upheaval. So this little arrow shows when that happened as part of the Seattle flu study. And this resulted in one of our first publications showing the tests by age group. And you can see we were testing in children less than 20. We were doing a lot of testing throughout the Seattle flu study because, in fact, children get flu. What I don't show you too well is the number of tests with positive results, which is the bottom of this graph, which really shows that nearly all the tests with positive results were in individuals over 15 years of age. And it wasn't really until the summertime that we started seeing COVID-19 or SARS-CoV-2 infection in children under 12 years of age. I'd like, before I get into some of the reasons why that might be, I thought I'd just show you some really beautiful pictures. These are pictures done by Trevor Bedford and the Hutch group, shown and published now in multiple different journals, showing the spread of SARS-CoV-2. And this first paper is published in Science showing the cryptic transmission. That means the secret ongoing transmission that was not known, but we found out later how much transmission was ongoing and how much viral change and mutations were actually ongoing in Washington state before we even realized that we had an outbreak. It's quite interesting. Washington is at the top in red, and I don't know if you can see my arrows, but these are all the spreads going on in Washington, and they had minor, tiny mutations, not the big ones that we call variants, but tiny mutations, which meant that we could track how people got it from one to another, and we could actually see how things were spreading. And the Washington sequence really took off, but it wasn't really to become the main variant or the main type of virus that spread within the United States. And I will show you that here, that the Washington ones were not the main. The 19A is some of the Washington ones here in purple. I've changed colors. But what happened was a big influx of variants from Europe to the United States, and the New York clades took off faster. So New York spread faster than Washington. Perhaps, one would like to think, perhaps because we had really early advanced notice in the Pacific Northwest, and perhaps because both Washington and Oregon really enhanced shutdown very early. Things happened very early in the Pacific Northwest. Amazon shut down. Our schools shut down by March 13th. We did a lot of early things. What is going on now, however, are the new variants that we're really concerned about. And these new variants are the orange ones here and the red ones here. And these are coming from here from South Africa and here from the United Kingdom. And those are the ones that everyone's concerned about and is making headlines. At this point, 1 year later, from the time I went out to draw the first patient with SARS-CoV-2 that had not gotten it from China, we're now 1 year later. We have 500,000 deaths in the United States and 2.5 million deaths worldwide. And it's totally shocking. We have been unprepared, and it's totally very, very sad. Now, here are some of the genetic variants and the things I was talking about in the last slide in a paper from January of this year. And the variant that we're concerned about here, is this B117 or the UK variant. And you can see here that it's in this orange line at the bottom, it's really coming up. And the reason we're concerned about this is perhaps it's not taken care of by the vaccine so well. The real concern is that it perhaps spreads better and it may be more serious. So we have some concerns about the new types of strains that have different mutations. So I just list them here. I'm not going to go into them, but you can't even open the newspaper these days without hearing about these variants. And the B117 is the UK variant. This one appears to be pretty well, if you have a vaccine, most of the vaccines do quite well against the B117, as opposed to the following one, the B1351 from South Africa. And that one perhaps does not is not going to be as well protected by the current vaccines. What I do want to show you is to go back to the Seattle flu study. The Seattle flu study was done to see how much flu there was and to detect a new pandemic flu. It was sponsored in part by the Bill and Melinda Gates Ventures group, because many people, including Bill Gates, is very concerned that there was going to be a flu pandemic. We, in fact, were prepared for a flu pandemic. We didn't have one. We had a coronavirus pandemic. But what I want to show you here is all these different colors, pink, purple, green, brown, are all the different viruses that infect children and adults, and that we had captured using our online and hospital-based surveillance system. And at the red arrow, you can see when we first identified, to the left of the red arrow is when we first identified the first community case of transmission, which was February 21st, identified and notified to the state February 28th. The stay home, stay healthy order was in March. And you can see with that stay home order, look at all the respiratory viruses plummeted. We lost flu, we lost para-influenza, we lost other viruses such as RSV, a baby virus, and they have stayed really low since that time. And this is really an amazing feat, meaning, maybe we don't need flu vaccines, we just need people to stay home forever. Well, that's a joke, because I don't think that's really a good way to proceed, but it is interesting that we were able to stop influenza and influenza outbreaks during this pandemic. So here's the question. Why did we not have influenza? And just to go on what Ruan was saying, we've talked about R naughts. R naughts are values of how transmissible viruses are. Flu is actually less transmissible than the SARS-CoV-2 or the COVID virus. And masking really can drive the transmission of flu way lower. We also know that people with flu have shorter incubation periods. They also are more likely to be sick when they have a lot of virus. And if you're sick and you have a high fever, you're often likely to stay home. However, in SARS-CoV-2, people often can have no symptoms. And particularly younger, healthy people have no symptoms, but they can have a lot of virus. So we think that there's a lot more asymptomatic silent spreaders in the SARS-CoV-2 world these days. And finally, flu and SARS-CoV-2 affect adults and children very differently. And so we do know that flu is really primarily spread in children in the elementary and high school level. School closures probably affect flu transmission disproportionately less. Flu is affected more, so there's less flu because of school closures than due to SARS-CoV-2, because we think there's relatively little SARS-CoV-2 transmission in schools, generally speaking. So let's go just back. I want to make sure that I talk about some of the other things I promised I'd talk about. And that includes, what about children? And I need to go through the definitions, which I originally had at the beginning, but luckily I think Ruan took care of many of these definitions. But I do want to make sure everyone knows that when you have a disease due to the virus called SARS-CoV-2, the disease itself, when you have a positive viral test, is called COVID-19 disease. The clinical symptoms of these diseases can be really nonspecific. You can't look at someone or look at yourself and say, oh, I have COVID-19, unless you or someone in your family's had a test, because the symptoms are really vague. You can have fever, you can have cough, you can feel tired, you can feel achy, you can have a headache, all of those things, some of those things, or none of those things. So that's why we really need to do the viral testing. And hearing that you and your organization are really involved in this testing is paramount, because we need to be able to diagnose this. Now, we know not all children have symptoms, and we know that not all the symptoms that children have are COVID-19. So it's difficult to diagnose this without a diagnostic test. And the tests we use these days are usually 3 different tests. And the most common test we have been using to date is this PCR test, which is a test done on a nose swab, and nowadays sometimes a saliva sample. And it's very sensitive. It's not that fast usually, might take several hours or a day, but it is very sensitive and it's a good test. We now have introduced antigen test. It's also a test done on a nose swab. It's really quick, usually less than an hour. It's not very sensitive. If it's positive, it's really positive, but if it's negative, you don't know for sure you're negative. So we're having a lot of debate how to use that test. And finally, we have antibody testing, which are blood tests, and it's evidence of past infection. And we're excited to be using the antibody test to really test large numbers of the population to really see who has actually had SARS-CoV-2, because if people are asymptomatic, you don't really know if they've ever had the disease or not. Now, if you look at the age distribution of confirmed cases, if you look on the left, looking at it by age group, you can see that children are really underrepresented. The top two lines, 0 to 4-year-olds and 5 to 17-year-olds, those kids make up less than 10% of the affected people, and they really make up about 20% of the population. So they are underrepresented in cases. And if you look at deaths, thankfully for the children, but bad for the older people, deaths are very much overrepresented in the older people over 65. You can take a look at this and you totally can understand why we have prioritized older people to be getting the vaccine, because the vaccine can prevent death, and these older people are and have been dying. Just to be really clear, in Washington State, and I don't have all the data for Oregon, but I'm sure it's out there too, but children represent 24% of Washington State population. They represent about 4% of the cases overall. They have been growing, but if you look 0 to 19, it depends where you start being a child. But really, if you go less than 12, it is only 4% of the cases. So young kids are either one, they're either not getting COVID-19, or two, they're not getting tested because they're asymptomatic. We are having increasing rates of PCR positivity, particularly over December. We had a huge rate increase of hospitalizations at our hospital, but we continue to have no deaths reported, which is good. We know that children have mild disease in general, and the epidemiology of the spread in children has not been well studied. And that's really terrible, because we need to restart school for the mental health of our children. And understanding the spreading, shedding, and long-term outcomes in children is really important. We are doing some research. This is a little boy I've cut off his head who's sitting with his toy teddy bear and getting his blood drawn for an antibody study. We are trying to understand antibody and how long it lasts and how many kids are actually infected in studies that we're doing at Seattle Children's Hospital. So how do children present? Kind of the same as adults. Usually they present with symptoms about an average of 6 days after exposure, with the common findings being fever and cough. There's recent debate about how many kids are asymptomatic, and it depends how you want to measure it. In some US studies, they speculated that 16% of children were asymptomatic, but other studies, including very large studies in Korea where they measured tens of thousands and tested tens of thousands of people, up to 50,000 people, they showed as about half of children have asymptomatic infections, meaning these kids can be infected and they're not showing any signs of disease, and we think they still can spread it. What we are noticing is that we have racial disparities in the confirmed cases. We have higher hospitalization rates in Hispanics or Latinos at all ages. And the deaths, which are relatively small, if you look at the total number of deaths, not very many, less than 100, but you can see that they are totally overrepresented in Black, non-Hispanic, and Hispanic populations. We also know that children have lower rates of infection overall than adults. And this is a study that we have been doing at Seattle Children's Hospital, looking at all the nose swabs in kids that come in. And of those kids that come in with symptoms that we think could be COVID-19, only about 3% are positive. We have a screening for children who need surgery, elective surgery. They need whatever, a tonsillectomy or tubes in their ears. They have to get screened before surgery. Only 1% of those children who look to be healthy are actually positive by a PCR test. And when we actually looked at our employees who were symptomatic, it was almost 4%. So in our hospital setting, children have much less COVID-19 disease. A study in India showed about 500,000 contacts, did PCR testing on 500,000 contacts in a really big study in 2 provinces in India, 2 states in India. And I think what was fascinating about this study, which was published recently, was that 8% of the people infected were responsible for spreading and causing 60% of the infections. So in other words, there's super spreaders out there, probably similar to the case that Ruann discussed with the cases in the gyms in Chicago. There's some super spreaders that spread it around. We now know from this Indian study that children can spread the virus among themselves, in the families, and to adults. And once they're in a household, the risk of children transmitting within the household is 9%, which isn't all that high. The high risk is if you sit on a bus or a train next to an unmasked person for over 6 hours, at least in India, you have an 80% chance of getting COVID. So why are children less likely to be infected? We don't have a good answer. And here's some hypotheses. I don't want to take a whole lot of time, but we think it might due to the receptor for the virus, or maybe there's some protection from other viruses. Maybe the certain kind of T helper cells are more protective in children. But I think we're all gaining belief that children really produce lower levels of inflammatory cytokines, and they do tend to have a more primitive immune response, and they do better with it than adults, which is very interesting. So going on to children, I want to make sure these are 2 kids in our study who volunteer to get their blood drawn every 3 months. They are champs. They are total champs. They are volunteering. They get like a $5 Starbucks card, and I'm proud of them and proud of them for volunteering in our study. We know that these kids can have asymptomatic disease, mild or severe disease. These kids had mild disease. But what we are now concerned about a lot is this delayed disease, which is called MISC, or Multisystem Inflammatory Syndrome, in children. And that's what people with kids are starting to get quite worried about. And that's what we see in our hospital. This is a defined disease. It's a syndrome. There's no single test that you can do. The CDC defines it as being under 21 years of age with 2 organs involved and no other diagnosis. Well, that makes it difficult. And they have to be positive for SARS-CoV-2 by either a PCR or an antibody test. So that's kind of scary. We're seeing perhaps 1 or 2 kids a week in our hospital. Some of them have pretty severe cardiac or renal involvement. What's perhaps more scary is now they're recognizing it in adults. So adults also are having this long-term multisystem inflammatory syndrome, and we're having all kinds of post-acute coronavirus syndromes, which to me means that we need more vaccine to prevent the disease in the first place. I'm going to go through that. I just want to show you one of our CDC-sponsored studies that we're doing in children, and I would like to say I am totally enthusiastic about how hard the CDC has been working, despite perhaps some political issues in giving out grants for this disease. We have at University of Washington, we have multiple CDC-sponsored studies where we work hand in hand with the CDC. And in this particular study, we are testing leftover blood from kids who come in the hospital or the emergency room, and we test 500 to 1,000 samples a month. And we can see that we have the rates of children who've been exposed to COVID in the past several months has gone from 2% to 3.1%, and it's actually up to about 3.3% now in November. We can also see that it's kind of equal among males and females, and it's divided among all age groups when you start looking at it. So I think we are seeing kids are getting infected. We might not recognize it, and most of them do quite well, unless the perhaps 2% who go on to develop the MISC. I'm not going to go through that. I want to briefly touch base about vaccines, because that's what I think are the most important topic that we need to address. We now have 3 different kinds of vaccines, one of which is licensed, the mRNA vaccine at the top. We have a viral vector vaccine on the left. That's the Janssen vaccine, or the Johnson & Johnson vaccine, which is very likely to get licensed this week. And then we have the protein subunit vaccines. which again is likely, I believe, to get licensed within the month. So that's great to have lots of choices. They all are good, they all are effective, and they all work. And that's amazing compared to where we were 6 months ago. The mRNA vaccine, which is the Pfizer and the Moderna, which some of you may have had and some of you might be lucky enough to get soon, is a lipid nanoparticle that encodes for the spike, or that S protein. And it's been licensed since 2020. And I'm not going to show that. People do have some concern about anaphylaxis, but I really think we need to put things into perspective. Out of the first 2 million doses, there were 21 cases of an allergic reaction. That is just, that's not very many. That's a lot less than we have to other vaccines. And I think the vaccine is really quite safe, but that's why whoever gets a vaccine is required to stay at the vaccine administration station for 15 minutes so that we can make sure they don't have a reaction. Now, what's going on with pregnant women? We know they have some increased risk for severe disease. We think their babies don't have that much risk. Babies do not generally contract SARS-CoV-2 by just being born to a pregnant woman. It has happened once or twice out of the millions of babies born. We are concerned about some being preterm, and perhaps SARS-CoV-2 could initiate labor. But what we're most concerned about is the pregnant woman getting pneumonia and having trouble breathing. So we do have a policy of giving vaccines during pregnancy. If we give a vaccine during pregnancy, the mom can make her own antibodies, which then get transported across the placenta, which is on the left, and into the blood system of the fetus. And so the fetus, and who then becomes an infant, will have antibodies present at the time of birth, which is really good. And that's why we give flu vaccine to pregnant women and pertussis vaccine to pregnant women, to protect both the woman and her baby. But going on for pregnant women, there is a lack of data for how to do this. There should be some data soon, but we don't have that much data. There are risks to the women for being infected, and particularly for our healthcare providers, many of whom are young women who may be or already are pregnant. There is a risk for adverse outcomes just by comorbidities if women have diabetes or hypertension. And there is the consideration of giving a COVID vaccine during pregnancy, because we don't want to give at this point in time a flu vaccine and a Tdap vaccine at the same time as a COVID vaccine. We don't have, people aren't really aware who to contact if they have side effects, and we have concerns about safety precautions. So pregnant women are kind of left floating in the breeze about what to do. The current documentation is to contact your physician, and physicians don't always know. So we at University of Washington and other places are trying to study this. And one study that's ongoing by Dr. Lisa Kachikas at the University of Washington is actually a registry for persons who receive the COVID-19 who are pregnant or breastfeeding. And here's the scan, and you can look it up, or you can contact me. I can give you the link. Well, the link is here at redcap.link COVID vaccine registry. And already Dr. Kachikas has had about 24,000 women sign up for this registry. And we are collecting a lot of data. It's not prospective randomized, but we're collecting good data on how well these vaccines seem to be tolerated in pregnant and or breastfeeding women. So what about vaccines for children? I'm nearing the end here. There are reasons to vaccinate children with COVID-19 vaccines. Lots of reasons. I can think of lots of reasons. As a pediatrician, I could probably think of about 200, but I've tried to simplify it. First of all, children represent a large proportion of the population. Children can transmit SARS-CoV-2, the virus. According to the American Academy of Pediatrics, about 1 in 10 cases are in children, and infection is a setup for the development of that severe inflammatory disease called MIS-C. There are consequences of COVID-19 in children due to this pandemic. We will have to be investigating this and treating this over the next 5 years, because the shutdown of school is really having immense implications. There are increased issues with mental health. Some of our children are not getting nutrition, they are getting abuse, they are not getting education, they are not learning to read. And these consequences really are due to the shutdown of the school system. And then very importantly, the ethical principles of distributive justice really expresses the idea that benefits and burdens are to be distributed among society's members in a just manner, meaning that children, and I could add here pregnant women, should not be excluded from consideration. We need to be just. We need to provide justice. We need to take care of those who could suffer the most. I just want to, this is a very cool paper. I don't have time to talk about it, but I just want to say that some of our pediatric blood from our studies are being used by our colleagues at Fred Hutch and Vanderbilt to really show how mutations to the virus can be tracked in the blood of people who've been infected or gotten vaccine. And Helen Chu and my group have provided a lot of the raw materials so that we can identify and potentially devise new vaccines for escape mutants. So as the virus changes, we can be on top of how to approach this. It's very exciting news. This just came out a little while ago. So we have a lot of questions that need to be answered about vaccines, long-term safety, data in pregnant women and children. Can we give it one dose? Do we have to give 2 doses? How much asymptomatic transmission is really going on, and does the vaccine impact that? There was a question in the chat box. We don't know. And if you're already known to be infected, do we have to give you a dose, or can we just get by with giving you 1 dose? All of these are really great questions. I don't have the answer, and I don't think anyone does yet. So future directions, we're going to do more studies. That's what we do, and it's important. Vaccine safety, immunogenicity, epidemiology. We are starting pediatric studies in March, so we will start in children ages 12 to 18 with several vaccines. And Seattle Children's website has the place if you want to volunteer your children, we'd love them. However, they have to get their blood drawn, so it's not for everyone. With that, I'd like to conclude by saying, by repeating a message from our governor, the governor of Washington State, from exactly a month ago. In January 21st, 2020, COVID-19 was first diagnosed in a traveler in Washington State. The loss we've experienced since that time is unfathomable. For many, it is personal. So we should think about the people we've lost. And I like the bottom, mask up Washington, mask up Oregon, mask up United States, mask up world. With that, I have a bunch of websites, as does Mrna, that you can actually look up and get up to date on our data. So with that, thank you. I will conclude and go back. I will try and leave my show so that we can ask questions.
Thank you, Dr. England. Thank you so much. And Dr. Barnabas and Martha, my name is Peg Chamberlain, and I am here to facilitate questions and answers. I want you to know that we are aware we are a little bit over tonight, but we are so grateful for 3 outstanding talks. And we have had Dr. Barnabas and Martha Newsom answering questions as Dr. England has been talking. Thank you so much, ladies, for furiously answering those questions. So you can do a couple of things. Please feel free to go into Q&A where you have asked questions and see that you might have already gotten an answer. And then we are going to take 10 minutes, even though we're a little bit over and we understand if you have to leave us, but we are going to take 10 minutes to answer questions specifically to Dr. England, especially since she's been talking. And I know there's a lot of great questions out there for her. So I'm going to start right away with a question from Christy York. What would you say to school board members, Dr. England, in Washington and Oregon about opening schools? What does the science say about opening?
Well, I think there's not that much science available is the problem. There's science about outbreaks and there's science about who's at most risk. But I do think that opening schools for children, certainly in the elementary grades, based on the data that we have, sounds like a reasonable thing to do. However, I really do feel for our older teachers, especially teachers with healthcare risk conditions, who should be getting vaccine. So yes, I think we should have schools open now for elementary school kids, but I also think that we should be able to vaccinate teachers who have at least those over 60 or so, or those with underlying health conditions. So we are doing actually several school studies. I've done several childcare studies, and we've found very, very little COVID disease in the children. The disease is in the staff, and the staff gets it from other people, like other adults. So the real danger is the staff going on a family picnic. It's not picking it up from the children who go to school.
Interesting. And a follow-up question on children. Does the course of infection in asymptomatic children resolve significantly faster than in asymptomatic adults?
Well, I think we don't know, because if you're asymptomatic, you don't have any symptoms. So I think if you don't have any symptoms, you still don't have any symptoms. So they're probably the same.
Okay.
Now, the good question would be, what about the viral load? Is the virus in asymptomatic children differ from the virus load in asymptomatic adults? And we actually, we do know that answer. And the answer is it's probably about the same. So.
Thank you. And how soon do you believe that children will be able to be vaccinated against COVID?
I think it's not going to be till perhaps December of this year, if the studies go well.
Okay. And I had a good question for pregnant women. Is there data to suggest either Pfizer, Moderna, or the new J&J vaccine is safer? Should they try to choose one over the other?
There's no data on any of them, so no. I mean, they're all safe.
Okay.
Yeah. So we are starting in 2 weeks, I believe, the Pfizer pregnant woman vaccine study. But I'm not saying it's safer. It's just that company is further along than the other companies in terms of, they were the first to get licensed there.
Okay.
They are more organized, perhaps, is the way to say it.
Thank you. And for your clinical trials, what age range is the term children?
Well, for our clinical studies, the hope is to go from 2 months to 18 years. But the way one does studies in children is you first do 12 to 18-year-olds and you prove it's safe and immunogenic. And then with the permission of the FDA, then you go down to 5 to 12-year-olds, and then often you go down to 2 to 5-year-olds. And then only after it's safe in all those groups would you go down to the infants.
Okay.
So that's why it's going to take so long. I think the vaccine could get approved earlier in 12 to 18-year-olds, and those are probably the ones that have the most disease.
Okay. It's my understanding that is the vaccine approved for 16 and up, or is that not correct?
It is for Pfizer and it is not for Moderna.
Okay. Is there any data on vaccinated pregnant women coming out of the UK or Israel that is way ahead in vaccinations?
The UK actually does not encourage and does not, perhaps Ruanne knows this I better than me, but the UK does not allow vaccination of pregnant women at this time. It's my understanding.
Yes, we will slowly gather data when inadvertently pregnant women are vaccinated in the UK.
Okay.
But the trials will be the gold standard.
Okay, thank you. And is there any advice from women going through IVF when it comes to getting vaccinated?
Well, my advice is if you're going through IVF, then you should try to get your vaccine before you go through IVF, because if you can. The problem is, you're right, perhaps you can't. If you're a healthy 30-year-old woman, you're not going to be able to get a vaccine right now. Most of us would recommend, I would just typically wait till the second trimester to get vaccinated. Not because I think there's a problem, but just there's enough going on in that first trimester with your life that it's just nice to wait. And most of our vaccine trials that I've done over the past 25 years with flu, we usually wait till women are about 14 to 15 weeks gestation before we would give vaccines.
Thank you. And how long would you anticipate the trials on children of all ages to be completed? Or I think she's asking how long before you believe all the trials will be done on children?
Oh, never. I mean, never. I think the Pfizer will be done soonest because they're starting the soonest, but Janssen's not even approved yet for adults, so they're going to be behind. And then Novavax, which I think is a good vaccine. Don't you think, Roanne, that that's going to go into children? That's a really nice protein-based vaccine. So I mean, once you start trials in kids, it's got to be at least about 8 months work to get down to the youngest kids and analyze the data. So once you start, it's still 9 more months. And what I'm telling you is Pfizer's the only one that started, to my knowledge. Actually, AstraZeneca has started some in the UK, but that vaccine is not yet getting licensed in the US because the trials are still ongoing.
Okay. What is the risk of antibody-dependent enhancement / pathogenic priming in older women who get the mRNA vaccine if they have comorbidities? My wife is curious about the trials, which included healthy people.
Do you want to go with that, Ruanne? Or do you want me to?
Oh, yeah. I'm not sure we know enough yet, but yeah, you go ahead, Janet.
Well, I think it's not true that the vaccines only included healthy people. The vaccine included people that had 1 or 2 stable comorbidities. And I think that's really important to realize that these vaccine trials are amazing. There's studies with 40, 50,000 people, placebo controlled, so only half got the vaccine, agreed. But these people were allowed to have a lot of conditions that, generally speaking, we don't allow to be in vaccine trials. So they were healthy, but that's not really the right word. They were stable. So you could have some kind of underlying disease. You just couldn't be on very much steroids, or you couldn't be on very much, you could have had cancer. You just couldn't be undergoing active cancer treatment, which probably your doctors wouldn't allow you to be in the trial anyways. So the question is, enhancement with the mRNA vaccine, I just don't think that's going to happen, but I don't think we know enough quite yet. What I would be more concerned about, I'm very concerned about this immune enhancement in the post-COVID syndrome. I think that is something to very much worry about. And I think people who are worried about the vaccine should take a look at what's going on with this post-acute coronavirus syndrome, or PACS, which is really getting publicity. Helen Chu's group published just last week a paper showing that 30% of people that had acute COVID still had symptoms, including peripheral neuropathy and even fatigue and shortness of breath 3 to 9 months later, 30%. So the rates of complications for COVID are just now becoming apparent.
Thank you, doctors. We have a couple more questions. What would you say to a woman who is hesitant to get the vaccine while breastfeeding?
I answered that question today for my daughter. And I said, what are they concerned about? It's great. There's no way that it's going to impact the baby except through breast milk. And for breast milk, it's going to give some antibody that may actually prevent infection in the baby. So actually, I had the debate, my daughter, the intern, who got COVID because there was not enough PPE. I shouldn't be bringing this up, but I do have these political feelings. And now she does have enough PPE, but she already got COVID before they had vaccine and before they had that. So I am feeling concerned for the healthcare workers and for the healthcare workers who are pregnant. And then for all these pregnant women who have these questions and we don't have data. So I don't have data. Ruanne, maybe you have something to add?
No, I was going to say the same thing, that passing on the antibodies would be a potential benefit, and we don't have any theoretical reasons to be concerned, but we don't have the data yet.
Thank you, doctors. Well, I have a couple more questions, but we want to be conscious of your time, and thank you so much for being here, ladies. This has been wonderful. I'm going to pass it to Kathleen now.
Thank you, Peg, for moderating our question and answers tonight. Hi, everyone. My name is Kathleen Bresky, and I'm a volunteer member of the Healthy Women, Healthy World leadership team. Thank you, Martha, for the medical team's update tonight, and Tammy for your reflection. I especially want to thank our speakers, Dr. Ruan Barnabas and Dr. Janet Englund, for their contributions to this evening's program and their ongoing work finding a way forward in this fight against COVID-19. To our audience, thank you for attending. We truly hope you found this evening informative, encouraging, and worthwhile. Now we'd like to give you a little update on our upcoming events. Please mark your calendars for our next quarterly educational events on April 21st, titled The Consequence of Global Warming to Healthcare. And our next book club will meet May 19th to discuss Well, Healing Our Beautiful Broken World from a Hospital in West Africa. We'll have a cameo guest appearance by the author, Sarah DeBarge. We sure hope to see you at future Healthy Women, Healthy World events. Good night, everyone.